This is Richard Schaefer I'm talking to, who treats Dupuytren's patients with radiotherapy and has been doing so for quite a few years now. Richard, if patients are thinking about radiotherapy, they think about all kinds of scary things. Can you explain what exactly is radiotherapy and what's the difference between the different machines?
Of course. Radiotherapy is radiation that we use for treatment. And we use this in very high doses to treat people with cancer. The reason why we do that is because cancer grows in an uncontrolled way in these very high doses. And we can also use it for non-cancer conditions. And obviously Dupuytren's disease is something that grows, but it's not a cancer, so it doesn't need such a high dose. We use around half the doses we use for cancer. Radiotherapy can be delivered either as X-rays, which we all know about, or similar types of radiation. And one of the main ones that we use is called electrons. The effect is basically the same as X-rays, so we just consider those two together. But they are delivered in a slightly different way. The big X-ray machines that we use to deliver radiotherapy for cancer are very, very high energy, and they're used to give radiotherapy deep within the body to very complex shapes. And we can modify those ones to deliver a type of radiation called electrons to the skin and to the tissues just underneath the skin. And that machine, these big machines, are called linear accelerators, or sometimes people call them LINACs. The other type of machine that we can use is a much simpler machine, and this delivers lower energy X-rays that naturally go to the skin and to the tissues just underneath. So we call those low energy X-rays or kilovoltage X-rays, or sometimes people call it superficial orthovoltage X-rays. So those are the sort of words that we use to describe the type of treatments within radiotherapy and the types of machines. In terms of when we give radiotherapy, so generally we give it either as a primary treatment. So what that means is you've got something going on in your palm and we just give it to stop it getting worse. Or we can give it post-operatively. In other words, once you've had a release of a contracture, we can give it after that. That's also called adjuvant as well. That's another word for post-operative, and it's basically to stop it coming back. In terms of the way that we describe the dose of radiotherapy, so the dose of radiotherapy is described in grays. So for instance, we might say 15 gray. That would be 15, using that dosing regime. And the total treatment dose, let's say we've got 15 gray as the total treatment dose, is divided into individual treatments, and we give one individual treatment each day. Each individual treatment is called a fraction. So in other words, we might give 15 gray total dose in 5 fractions over 5 days, in other words, with each fraction being 3 gray. So 3 gray times 5 fractions is 15 gray. And then for Dupuytren's disease, we give that 15 gray in 5 fractions over the 5 days, or we say over 1 week. We then have a gap of 3 months, and then a further 15 gray in 5 fractions over 1 week. So the total dose is 30 gray in 10 fractions, but it's given over those 2 separated weeks. Each week is called a phase. So in other words, phase 1, 3-month gap, phase 2. In terms of other words that we're using, we often talk about things like planning and markup. So if you're having some very simple treatment with electrons or with low energy X-rays, then generally what we would do is we would see you for the markup appointment, and literally we draw around with a felt tip pen the area that we're going to treat and the area that we're going to shield out. Sometimes people have a slightly more complex way of doing it, and they might have what's called a planning CT scan. So a CT scan is a little bit like a 3D X-ray, basically. And we use that not to look for anything, not to diagnose you with anything, but really to direct the X-rays towards the right bits. And that's really used with the more complex type of radiotherapy techniques. There are people that use those. And I think it's not unreasonable that people do it, but perhaps it's a little bit more complicated than it needs to be. So planning CTs, again, very standard part of radiotherapy planning, and that often, again, is used in order to mark up the area that needs treatment. When you actually come to your treatment, the reason why we mark it up, either on a planning CT or just with a felt tip pen, is to work out which bits we want to treat, which bits we want to shield out. And in order to deliver that, we often need to make a shield. so that we can shield out those bits. And that's often made out of metal. It can be just literally, put on the hand, or, when we treat you for the more simple types of treatment. Well, sometimes it's in the head of the machine if you're having it with the bigger type of machines, the Linacs, the linear accelerators. And so that's when we make the shield, and sometimes that introduces a bit of a delay before we can start your treatment. The last thing to say is that with electrons, if we just gave the electrons straight onto the hand, the radiotherapy would be delivered too far underneath the skin for it to be useful. We therefore put a sort of waxy material on the skin, and we call that bolus, and it fools the electrons to thinking that the skin surface is a little bit in front of your skin, so that therefore the dose is delivered to the skin surface. It's just a way of giving the radiation full dose to the right place. So that bolus material, or the wax material, is also something that is used as well. So those are some of the words that we use when we talk about radiotherapy.
That explains a lot for patients. Thank you.